So it can be mixed with the Kawasaki disease. So that's why you have to see. And mainly the sandpaper rash generally develops over the perioral area. So giving the same amoxicillin and erythromycin is the treatment. Then comes the rheumatoid fever. Rheumatoid fever, you need to know the John's criteria. I mean, yeah, John's criteria, and then going for two major, one minor, or two major, sorry, one major and two minor. So, what are the major ones? Carditis, valvulitis, arthritis, CNS, Senden-Chorea, subcutaneous, and all that. Minor is basically arthralgia, fever, CRP, PR intervals, this one. And treatment is same penicillin or the erythromycin. Prophylaxis is basically the penicillin anyway. Complications, as it can be involved to many of the symptoms and involve mainly the heart. So here is the M-Centaur score. What are the scores is basically the age factor must be more than 3 years. The cuff, there is no cuff. The tonsillar exudates should be there. So tonsillar exudates should be there. Anterior cervical lymphadenopathy, temperature, only young, rarely elder. So in those cases, M-Centaur score is basically if this is 1, no further testing or antibiotics is needed. If 2, consider rapid testing or culture. If 3, then also consider rapid testing and the culture. In the 4th, you can do the rapid testing, culture, and at the same time, you can start the antibiotics as well. Then comes the post-streptococcal glomerulonephritis. Why I'm doing it because they all are linked with each other. So the treatment is kind of same. How does they can present? So they can give you in a different ways where they can ask you, okay, this could be the diagnosis and this could be the problem. Now make the diagnosis. So, that's why I'm just reading this one as quickly. So it can present with a microscopic and macroscopic hematuria to all the nephritic disease, and then it can be confirmed with the complement level like C3 and C4. Otherwise, you can also go for the streptococcal titers, antigens basically. Then comes the meningitis. In the meningitis, we already know what you need to remember: the CSF culture and their levels. If it's TB, what is the thing? So here it's the thing. If CSF finding of the meningitis, so it's the if the lymphocytes in the normal, it should be less than 5. In the normal newborns, up to 30. In bacterial, it's less than 100. In the viral, it's very high, and tuberculosis is also very high. Then neutrophils is normal. Then no newborn, it's also normal. Then the meningitis, it will be very high. In the viral, it should be less than 100. In tuberculosis, is less than 100. Glucose, so bacteria eat glucose. That's how I memorize. So glucose in bacterial is low. Otherwise, in viral, it's normal. And then in TB also eat glucose, so it's kind of low. So try to make sense with that. Then comes the protein. In protein, the bacteria does not eat the protein, so it will be high. In tuberculosis, it should be 1 to 5, not very crazy high, but viral should be 0.4 to 1. So like within mediocre level. Then when we are talking about meningitis, how you're going to start like a full septic workup, because a child can present with fever. So we have to do the full septic workup, then going for lumbar puncture and all that. Sportive care is basically presentation of the adequate cerebral perfusion by maintaining the normal BP and then managing the ICP, close monitoring of the fluid, electrolytes, glucose and acid-base disturbances, coagulopathies. Then the bacterial meningitis, if suspected or cannot be excluded, commence the empiric antibiotic therapy while waiting cultures or if the LP contraindicated or delayed. Then the adjuvant dexamethasone before antibiotics should be used. Dexamethasone is something which can help with the cerebral edema. So in those cases, going for dexamethasone. Then the what it says isolated with the like infection can spread, so it's important to isolate. And then fluid restriction, hearing test is one of the most important because like when it comes to children, wherever there you feel like it can affect their hearing, so go for the hearing test like thing. And then report to the public health. So think of where you can report the public health. Then there is the antibiotics. So you need to remember with the age which antibiotics. So 0 to 8, you give amoxicillin or ampicillin to cefotaxime. Then 28 to 90, you go for cefotaxime plus the vancomycin. And more than 90, it's basically ceftriaxone with the vancomycin. So you need to remember the name of the antibiotics, especially for the meningitis for age factor. Which age for which one, okay? Signs of meningismus is basically Brudzinski sign of cystotonus. So why you need to remember this one? Because it can be mixed with the tetanus. So that's why you need to know the knuckle rigidity and then kerning sign. Then the mumps, in the mumps, the main is basically, let me show you here. Usually followed within the 48 hours by parotid swallowing and then secondary to parotitis. So it's a clinical diagnosis. Don't go for throat culture and sensitivity. Okay. It's a clinical diagnosis, but maybe confirmed with IgM or whatever you can go for. So usually in our practice, common practice, we don't go for anything. We go for clinical diagnosis. Then it's basically a viral, so analgesics, antipyretics, and warm and cold compression. Then always think of other like aseptic orchitis, one of the most important orchitis, and then euphoritis, encephalitis, pancreatitis, thyroiditis, and myocarditis. Then pertussis, it is very, very common in like people who are like refugees and usually with the non-fully immunized. So if first thing I would suggest when you are talking about anything, if they given you in the scenario that the patient is not immunized fully, so in those cases, think of pertussis as well in your back of your head. So it's a very common one, especially less than 1 year, not fully immunized. So usually they will say that he was immigrant or the parents was reluctant with the vaccine. So they will talk a little bit about something that will give you an idea that he's not immunized. Okay. So there is different levels, stages like etarral, where there's only upper respiratory tract infection, then paroxysmal, which is basically with the cough, whooping cough, and then the post-tussive apnea, and then the yawning, sneezing, and post-tussive emesis. What are the investigations? NP specimen, usually aspirate, or take the swab, gold standard, then the PCR and all this one. So admit if there is apnea going on or cyanosis, sportive treatment, and going for antimicrobial. And then, one of the most important is giving the prophylaxis to the home household. It is very, 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 very important to talk about the household prophylaxis because they can give you a scenario and they're not interested in management. They can ask you what is the next step you would like to do. So one thing, reporting to public health. Then second thing, offering the prophylaxis to household means that the other siblings or whatever person is living at home. So in those cases, what do you give is macrolide antibiotics for the household. Then prevention with the vaccine, and always talk about the vaccines. As I said, it's one of the things that you have to always mention for the vaccine, even though you have talked about in the previous visit as well. Then complications, pressure related paroxysmal and the neurological. So subconjunctival hemorrhage could be one of the most important that can present in the arachnoid prolapse. So they can present with the subconjunctival hemorrhage and asking you to make the diagnosis as well. So in the children, this is not something very common, but usually it's this. When we are talking of pediatrics and we are talking about subconjunctival hemorrhage, so there is one question, and I don't know if you can find the answer in the Toronto notes. It's how do you do the screening for the vision in the newborn? How do you do the screening for the hearing in the newborn? Okay, so let me just see if we can find it here. Just give me a second. How do you do screening in newborn? Sorry, screening of hearing newborn. According to my knowledge, usually we do our voice testing. If we talk and then child turns toward you, it means his hearing is intact. That's what my knowledge is about. But yeah, sure. So yeah, here is this. Hearing screening is basically checking for the autoacoustic emission or automatic auditory brainstem response. So what are the names? So this is the name. Okay. So what are the name is basically automated auditory brainstem response. Just write it down, highlight it. It's very important. Then response screening of vision in newborn. So in this one, you have to figure out the retinoblastoma because that's what they are looking for. So red reflex test. Okay. So the hearing was automated something something. I don't know what was the word. Yeah, automated auditory brainstem response, and the for the vision, it's basically the red reflex test. Okay, so I just want to make sure that you guys can write it down on the side. It's kind of, you know, just keep it in your head. It's kind of stupid. Then cardinal signs of the orbital cellulitis, ophthalmoplegia, proptosis, then decrease or visual acuity and pain with the extraocular eye movement. Okay, so just to correct myself, for the sensory neural hearing loss, for the children vision, we were doing this whatever test, automated whatever test was. But in the older people, we checked the voice test. Okay, so we talk and then they ask them which, if they can listen, then turn towards that side. So if they can do that, it means their hearing is intact. That's for older people, not for the younger people. Sorry, for the newborns. Then comes the sinusitis. So it's mainly the diagnostic imaging is not required. So it's upper respiratory tract infection. Then comes the most important topic of urinary tract infection, because with the fever, you always have to keep that in your mind that this is basically urinary tract infection. And it's very common in the females. 4 to 6 week, more common in the males. And after that, 1 year, it's females. High grade fever, flank pain, severe tenderness, think of pyelonephritis. Bagged urine specimen not used, so urine dipstick you have to do. Then in that case is do physical examination, toxic looking, non-toxic. So all whatever we did for the fever, same thing goes here. Usually we go for urine dipstick because it's very convenient, do it right away. But later on we go for urine complete and then urine culture and sensitivity. So in that case is giving the paper and then they will do everything. In those cases, what are you looking for? Leukocytes, nitrites, hemoglobin, and blood. That's the 4 things that you are looking for in urine dipstick test or in urine complete. That if they have even a little bit of blood, you should be concerned about it. But in the females, we think of menstruation as well. So always rule out that one. Then the microscopic bacteria looking for whatever it is. Then diagnostic is the urine analysis suggestive of the infection. So in cases, when are you going to do what? So as we already know, the fever one. So if this is less than 2 months or less than 1 month, usually we go for the admission anyway. If there is a persistent vomiting, urosepsis, oral medication is not tolerated, dehydration, immunocompromise. So where you feel like, yeah, this patient needs to be admitted. Then sportive management, you give for hydration, pain control, antibiotics, as we already discussed. So in this one, the neonates, you go for IV and ampicillin, and then infants or the oral one, you go for the oral antibiotics. Then in the imaging, you need to figure out renal and the bladder ultrasound for all febrile infants less than 2 years. Okay. Why? Because they could have a congenital anomaly, polycystic, whatever could be there, or any glomerulonephritis could be there. So in that case, is going for imaging and mainly the ultrasound. Recurrent, if there is recurrent UTIs are there. Then VCUG not recommended. Follow up patients. So it's every 24 to 48 hours. There is no prophylaxis. Now coming to neonatology. So let's go to my notes first, because I think in my notes there is more nicely the neonatology is written. But yeah, like here I would mention one thing before going there. Abnormalities of the gestational age and size. So premature, preterm infants less than 37. One of the most important thing is basically testing for what kind of electrolytes. So hypocalcemia, hypoglycemia, and hypothermia. Just regardless of whatever it is in preterm. So if there is any problem going on, always think of these 3 things before going for anything, because it's very common. So a spontaneous cause could be there, hypertension. So mother could be anything that is related to this one. But in the children, the hypoglycemia, hypocalcemia, and hypothermia. Then the other things, anemia, jaundice, prematurity, PDA, all of those ones. In the postterm, the meconium aspiration, birth weight is important. Clavicle fracture is very, very important. SGA, like short for the weight, gestational age. So less than 10 percentile. In this one, the important is symmetry and asymmetry. So asymmetry is head sparing and then late onset and growth arrest. So in that case is like, I think if it's a asymmetry, they do survive, but if it's like a symmetry, then in those cases they don't survive, something like that. Yeah. If there is a head sparing, they do survive because their head does, or they don't have any CNS abnormality. If this is a symmetry and there is no head sparing, then they don't survive. I mean, after a certain period of time, they do die or something, like with the torch infection and all that. So this is a question for asymmetry and symmetry, which one survive or something like that. Okay. Large for gestational age, there is diabetes, weight gain, or all of that one. So what are the birth trauma could be there, like as we talk about, then perinatal depression could be there, like meconium aspiration, jaundice, polycythemia, hypoglycemia, and then hypocalcemia. So as you can see, hypoglycemia, hypocalcemia, hypoglycemia, hypocalcemia, in many of the cases it's written there. Okay. So let's go here. So we're talking about Wilms, and then we are going to neuroblastoma. Neuroblastoma is the adrenal medulla tumor, similar to the pheochromocytoma, but with the fewer cardiac manifestation. The percentage will be basically metastasis ranging, and then increase the when WMA and then metanephrine, so having high blood pressure. So then the hydrocele is the painless swollen fluid filled sac along with the spermatic cord. In this one, what do you do? The most important is transdomination test. So in this one, it resolves within 6 months. Then the varicocele is the varicose vein in the scrotal vein. So there is a like a pampiniform plexus. The most common complaint is the dull ache and the heaviness. Best test is basically checking for the physical examination, checking for the bag of worms, then going for ultrasound. Treatment is indicated for the delayed growth of the testes only when you feel like this is a testicular atrophy. Always do ultrasound the other testicle as well. It could be bilateral disease. So if one is showing and the other is not showing, so think of the other one as well. Cryptocorchitism is an absence of one testicle in the scrotum and is usually found within the inguinal canal. 90% of the cases can be felt in the inguinal canal. Then you do the surgery, and when you do the surgery after 4 months, so you do the go for the surgery after 4 months, and definitely should be completed before the years of 2 year. So after 4 months, before 2 year. Then we were talking about the teratology of Fallot. So it's mainly come with the overriding aorta, pulmonary stenosis, right ventricular hypertrophy, and then ventricular septal defect. That is one. There are the only three holosystolic murmur. What are those ones? Mitral, tricuspid, and then ventricular septal defect. Teratology of Fallot representation or the diagnostic is early and sware cyanosis is seen. So it's an egg on the X-ray agon string. So then neonate is basically open PDA, must have open PDA. And what do you give is prostaglandin E1. And SAIDs are contraindicated because they cause the polio. Most common cyanotic condition in the children's and the neonate is transposition of the great arteries. Okay, so don't go for TOF. It's transposition of the great arteries. Then the ventricular septal defect is the most common congenital anomaly. That's why I think at least you should read this one. Dyspnea with the respiratory distress, high pitch hollow systolic murmur is there on the lower left sternal border, and the loud pulmonic S2 diagnostic. Test is chest X-ray shows the increased vascular marking, echocardiogram is diagnostic, and then cardiac catheterization is definitive. Treatment is smaller lesions and making the prevention of CHF and giving diuretics and digoxin. Uh, it's not you have to go for the treatment, mainly just the diagnosis. Pansystolic, holosystolic is equals to throughout systole. VST, we give diuretic and digoxin. Then comes the AST. In this one, just it's are more common in the women as in the men. And we do the chest X-ray show increase the vascular marking. Yeah, here. It can cause possible DVTs in the later on. So think of AST can cause DVT. Mitral lesion radiate to the axilla and tricuspid, and the pulmonary radiate to the back, and aortic radiates to the neck. Cardiac X-ray finding spear shaped, pericardial, then boot shaped is teratology, and then jug shaped is primary pulmonary artery. Three line like appearance of the rib is basically coarctation of aorta. Coarctation of aorta, if the exam questions mention a short girl with a webbed neck, shield neck, sorry, chest, streak gonads, horseshoe kidney, or the shortened fourth metacarpal, think of the coaptation of aorta. So I think that's it. Best treatment for the long QT intervals, beta blocker or metoprolol. Patient with abstinent anomalies, mainly with the lithium, mother is taking lithium, may have the Wolff Parkinson disease. Okay. Pathology jaundice in the newborn hyperbilirubinemia is considered pathological when it appears on the first day of the life. Bilirubin rises more than 5, bilirubin rises 19 in a term. Direct is above 2. Hyperbilirubinemia persists after the second week of life. The most serious complication is the deposition of the bilirubin in the basal ganglia. It can cause connectors and presents with the hypertonia and then sears, chorioathetosis, and then hearing loss. Let's go back to this one here. So how do you go for the routine neonatal checkup? Checking the history and then erythromycin of ointment. A lot of people don't go for this one, but usually this is the one that's for the, and then vitamin K. So this can be asked in the question, what, when the newborn is given, what is the first primary care? So if they can give you an MCQs, giving you multiple options and ask you what is the most important one. So most important one is vitamin K more than erythromycin or anything else. Okay. Then newborn is basically a screening test in Ontario. So here is the screen test that we are talking about, but they did not mention about something else. So metabolic disorders, blood and endocrine, and then congenital hearing test. So what was the test? I don't know, automated something something. If the mother is Rh negative, in that case is how do you give? Then how household contact in a hepatitis B positive, start the hepatitis B vaccine series in that one. Then the ABGAR score, we already discussed this one. In this one, the initial resuscitation, pre-delivery, stimulate, positioning. This is important too because they can be asked if the ABGAR score is low, what is the next step you will do? So you need to know at which level you need to do what. So if this is basically an ABGAR score of maybe 5, in that case is don't go for something else. Starting with the warm. Okay, most important is starting with the warm and the dry, the new baby, and then stimulate the infant. Maybe he's sleepy, or in that case, is rub the back and the fluid sole of the feet. Then the positioning airways. So then making the sniffing, and so don't just directly jump to that one. Always start with the warm, stimulate, then positioning, then assess breathing and heart rate, then go for apnea, ineffective respiration, or heart rate is less than 100. Then start with the bag and mask ventilation with the room. If the heart rate is less than 20, 60, effective ventilation, start compression. If meconium present, then you have to do the resuscitation skills. If the newborn is hypotonic with the ineffective respiration, then go for the intubation. Do initial resuscitation and then administer PPVs. Okay. So corrective action of the PPC is basically mask and then reposition, suctioning, open mouth pressure, and alternative ways. So always start with warm because we do forget. I mean, I myself forget. Warm, stimulate, and then go for like positioning of the airway. So these are the drugs that you give. What is this one? Epinephrine and then fluid. Then what are the different respiratory depression? Then it could be RDS, pneumonia, pneumothorax, just for your knowledge. How do you assess the vital signs? Checking for pre and post ductal oxygen, then maternal and labor history, then clinical diagnosis, then laboratory checking for CBC and everything, then transillumination test for the chest to make sure that there is no pneumothorax, then chest X-ray, ECG. Then the management, we already discussed how you do the resuscitation. Even in apnea, we do the same chest X-ray checking for all that. In apnea, think of stimulation first. Which one? Tactile stimulation. This is the word. Okay, this is most important word. And if they ask for medication, it's mainly the caffeine, methylxanthines. Okay. Then we talk about the bleeding disorder. Because the vitamin K, and they can give you the baby was not born in the hospital. That can give you an idea that he was not taking anything. Thrombocytopenia presents with petechiae and purpura. IVIG is the one that is given. Autoimmune presents with the mother who was having the problem, so steroid to the mother. So that cases. Then the vitamin K one. Let's do this topic and then we can start from cyanosis from tomorrow. So bronchopulmonary dysplasia, also known as the chronic lung disease, then defined as oxygen requirement for more than 28 days. So it's basically you give the oxygen or ventriculatory support at 36-week corrected gestational age and going for more than 28 days. Then damage to the developing lungs. So you do the chest X-ray, no dearly effective treatment, only the ventilator. Dexamethasone should be given and checking for uh, the lung development. Okay, so dexamethasone can help the inflammation and encourage the weaning, but use of dexamethasone is associated with the risk of the adverse neurodevelopmental outcome. Think of this one, okay? They can give you a scenario where they can give you a bronchopulmonary dysplasia. You are given the treatment. Now, what could be the consequences? So they will not tell you the diagnosis, they will not tell you the treatment. They can give you only a question where you have to make the diagnosis of bronchopulmonary dysplasia, and you need to know the medication that was used, and now they are asking you what is basically the consequences of that whatever medication. So dexamethasone obviously can cause another whatever autoimmune problems, but the main problem in the children is neurodevelopmental outcomes. Then the prognosis is chronic respiratory failure may lead to the pulmonary hypertension, poor growth, right-sided heart failure. Patient with the bronchopulmonary dysplasia may continue to have a significant impairment and deterioration. Some lung abnormalities can persist in the adulthood. So think of this one, like what can be the consequences of later on. So what are those ones? Obstruction and emphysema. Then the increased risk of adverse neurodevelopmental outcomes because they're using steroid. So the prognosis is very, very important of this one, and it can be asked in the question. Okay. So I think that's about it for today. Do this one. Okay. One